Good morning again, everybody. Dr. Barron sends his apologies. He's unable to be with us. However, today we'll be talking about the possibility of using thermal imaging as an adjunct to tell us whether or not our REBOA is actually being effective in a field environment. We have nothing to disclose. However, we would again like to thank the AMED Advanced Medical Technology Initiative for providing us the funds to perform this procedure. Now, we've well established through the presentations we've already heard today that hemorrhage is by far the most common cause of preventable battlefield death. However, when you think about this, it's always good to kind of split it into three different functional categories, being extremity, junctional, and non-compressible truncal hemorrhage. And while we've made significant strides on extremity and junctional hemorrhage, non-compressible truncal hemorrhage remains a significant problem. One of the potential treatments for this type of mortality is the REBOA, or retrograde endovascular balloon occlusion of the aorta, which has demonstrated an emerging role in pre-hospital treatment. We have multiple different studies that have demonstrated the feasibility of using this in the field, and then a case series where we've actually been able to utilize this going from point of injury to surgical care. But in thinking about actually pushing this to a broader scheme, REBOA has a number of barriers to its actual utilization. Namely, the first two deal with a lot of training and specifically safe utilization and patient selection as we try to push this out to ancillary providers and additional non-surgical providers. As we start to think about moving these patients and transporting them actually to surgical capabilities, however, I'd like those of you who've been deployed to think about the most austere environment you've been in, the place that has very little lighting, the place that has a lot of... Can we start that video? Thank you very much. The place that has minimal ability to hear, you're not sure if you're able to feel for pulses because you don't actually know where you're actually feeling. You may not have Dopplers around. You really are in the back of a helo with no lights, no ability to know what really you're doing. And for those of you who haven't deployed, just think about you're trying to figure out whether your REBOA is working and you don't have any of the fancy technology that's in your emergency department. With this in mind, we looked to thermal imaging as a possible adjunct to help us figure out the efficacy of our interventions. Thermal imaging at this point in time has now become a very low cost and portable alternative that is actually relatively intuitive to interpret. And we hypothesized that this mobile phone-based thermal imaging could provide a prompt, accurate, and reliable assessment of REBOA placement in people with minimal training. To perform this study, we took 10 Yorkshire swine. Half of them were hemorrhaged 40% by weight. The other half were without hemorrhage. We then did an open iliac cut down and placement of a CODA REBOA catheter. We then took baseline thermal imaging of these swine and then inflated the REBOA. We took intermittent FLIR imaging every 5 minutes until completion of this 30 minutes, at which point we brought the balloon down and allowed the swine to recover. After sufficient recovery, we then randomized the animal to either have the REBOA reinflated or have a sham procedure where the REBOA was quote unquote not inflated. And we performed the same 30-minute experiment with continuous thermal imaging. After allowing them to again re-equilibrate, we then did another randomization under blackout conditions. This is merely to familiarize yourself with the idea of the thermal imaging, and this uses a standard Ferris thermal scan, whereby white is hot, and as you go through the lighter reds to darker reds to greens and finally to blues, you go from your hot to cold color scheme. On the left-hand side, you can see the baseline image, which has a smattering of whites and lighter reds. And as we move from the left side towards the right side, down our time decrement, we see the loss of those whites into darker reds and finally into greens creeping in from the extremities. This is a time-elapsed image of a 30-minute REBOA inflation on this pig, and I would like to just point out to you, you can see the whites, especially in the center mass of the pig, and as you look at the right lower extremity, you can see the greens starting to creep in as the reds get darker and darker and darker. And during this experiment, we focused on the right lower extremity due to the placement of the REBOA catheter in the left iliac, possibility of kind of confounding that data, so we told people to focus on that right lower extremity. We then took 62 blinded evaluators with significantly varied levels of training, going from medical students all the way through attending physicians with roughly 50 years of operative experience. Of importance, none of them had any experience with thermal imaging previously. We then gave them a 5-minute group familiarization, going through REBOA technology and REBOA techniques, and then going into thermal imaging and what it specifically meant. We then provided these providers with 3 images. The first was a reference image with the REBOA deflated. You can see again the whites and the lighter reds. The second was a reference balloon inflated image, which demonstrated significant greens and darker reds, as you can see. And then we showed them the center image, and we asked them a binary question. Is the REBOA inflated or deflated? As you can see here, the blinded evaluator analysis demonstrated significant accuracy at our 2 earliest time points, being 5 and 10 minutes, and it remained similar in both our non-hemorrhage and our hemorrhage models. The same accuracy held strong through both light and blackout conditions, demonstrating no difference statistically or otherwise. Moving beyond the subjective data, we also were able to get objective temperature measurements from the aggregate of the right lower extremity, and we noticed significant decrements as we go forward in our time frame. Looking specifically at the sham interventions, they did not show the same decrement. So there was a statistical difference between those 2 groups. Now, this was a porcine model that had a limited injury without additional issues and complexities that go along with that. Additionally, it was a controlled environment that was kept at 69 degrees throughout the entirety of the procedure, so we didn't have to deal with the other hypothermia that goes along with transport. However, this proof of concept has suggested that FLIR imaging allows for accurate identification of an adequately placed REBOA, along with easy identification with novice observers through limited familiarization. And finally, it was also able to show us objective data with decrement in temperature throughout that time. We concluded that thermal imaging is accurate and simple as a modality to assess REBOA efficacy that wasn't affected by either lighting or blackout conditions, and it demonstrates a promising future in both austere environments and significant transport. At this point in time, I'd be happy to take your questions.